Hello everyone. So today we start the topic of pelvis and perineum. In this topic we would study about pelvis and its division, its connection and fatty spaces, pelvic diaphragm, male and female perineum, all the vessels, nerve plexuses, all the organs, urinary bladder, urethra, scrotum and testes, all the gonadal organs, and also operations. So first is pelvis and its borders. Okay. Now borders are anterior, posterior, lateral. Anteriorly, there are two hip bones, which is coxal bone, innominate, which is also innominate bone. Next is posteriorly sacrum and coccyx. Laterally, two hip bones are there. Now this pelvis is divided into greater and lesser pelvis by pelvic brim, which is a terminal line. Pelvic brim is formed by the sacral promontory, arcuate line of the ilia, pectinate line of the pubic bone and superior margin of the pubic symphysis. Pelvic brim is formed by sacral promontory, arcuate line of ilia, pectinate line of the pubic bone and superior margin of pubic symphysis. Now, this greater pelvis, which is also called as false pelvis, and lesser pelvis, which is also called as true pelvis, there are borders. Anterior of greater pelvis there is nothing, but anterior of lesser pelvis there is pubic bone. Superiorly, in inferior floor of abdominal cavity is of the greater pelvis and lesser is pelvic brim. Inferior of the greater pelvis is pelvic brim and lesser pelvis there is nothing. Laterally, greater pelvis it is surrounded by wings of iliac and lesser pelvis is ischial bone. Posteriorly, there is lumbar vertebrae of the greater pelvis and sacrum and coccyx of the lesser pelvis. Fine. Now, this lesser pelvis, which is a true pelvis, it is divided into three. Okay. Three subdivisions are there. What it is? Inlet, cavity, outlet. Okay. Pelvic inlet, which is also superior aperture. Borders of pelvic inlet are anterior, posterior, lateral. Now, inlet, anterior is pubic tubercle, superior margin of pubic symphysis. Posterior is sacral promontory and laterally there is arcuate and pectineal line. Cavity, anteriorly there is pubic symphysis and subpubic rami. Posteriorly there is sacrum and coccyx. Laterally there is inner surface of bodies of rami of the ischium. Outlet, anteriorly inferior margin of the pubic symphysis. Posteriorly there is tip of coccyx and laterally ischial tuberosity is present. And also ligament of sacrotubercle is present. What are bones of pelvis now? Bones of pelvis are three. Hip bone, sacrum, coccyx. Hip bone consists ilium, ischium, pubis. Okay. See. Next is joint of pelvis. Joints of pelvis. Now first is sacroiliac joint. Now this sacroiliac joint, it is a synovial joint which is covered with fibrous cartilage and it is strengthened by following ligament: interosseous sacroiliac ligament and iliolumbar ligament. Okay. Next is anterior sacroiliac ligament which fuses tightly with the capsule, and next is posterior sacroiliac ligament which connects anterior superior iliac spine and posterior superior iliac spine. Now there are four ligaments which strengthen this sacroiliac joint, sacrum and iliac joint, which is strengthened by four ligaments: interosseous sacroiliac ligament, iliolumbar ligament, anterior sacroiliac ligament and posterior sacroiliac ligament. And also this joint is covered by fibrous cartilage. Next is pubic symphysis. Now pubic symphysis, it is a fibrocartilage interpubic disc which is strengthened by superior inferior pubic ligament and arcuate pubic ligament. Okay. Now next is sacrotuberous ligament. See, sacrotuberous ligament, it connects the ischial tuberosity to the lateral surface of sacrum, ischial tuberosity to the lateral surface of sacrum and coccyx, and it forms the lesser and greater sciatic foramen together with sacrospinous ligament. Now we have studied this in lower limb. Okay, so review that video so you would understand in more detail about greater and lesser sciatic foramen. This two ligaments, sacrotuberous ligament, sacrospinous ligament, it forms greater and lesser sciatic foramen. Next is obturator membrane. Now this obturator membrane, it is a fibrous plate covering the obturator foramen attached to the obturator groove and converted into obturator canal. Obturator artery, vein and nerve passes through this canal. Now muscles of pelvis. What are those? There are two differentiation, parietal and visceral. Now in parietal, there is iliacus and psoas major. Now this iliacus and psoas major, it makes iliopsoas muscle. Okay. Next is obturator internus, obturator internus, obturator externus, piriformis muscle, superior gemellus and inferior gemellus. What are the muscles? Parietal muscles of the pelvic: iliopsoas muscle, obturator internus, obturator externus, piriformis, superior and inferior gemellus. Viscerally, there are levator ani muscles. Now three muscles combine this levator ani. Which are those? Puborectalis, pubococcygeus and iliococcygeus. Puborectalis, pubococcygeus and iliococcygeus. Puborectalis, pubococcygeus, iliococcygeus. These are levator ani muscles. Next is coccygeus muscle. Okay, and external anal sphincter muscles are also present. Now fascia and fatty spaces. There are two fascia, parietal and visceral. Parietal, it covers the wall, and visceral, it surrounds the pelvic organs and form two septa, sagittal besides the organ. It separates the fatty spaces located around the organs of lesser pelvis. Now there is a peritoneal fascia, perineal fascia. It is a transverse direction between the two septa of visceral fascia and separates the fatty spaces of lesser pelvis in two compartments. This perineal fascia is also called as de Neuvillers fascia. Now these two compartments are Purgove's radius and Amusat's capsule. The fatty spaces are prevesical, paravesical, retrovesical spaces, which is prevesical, also called as retropubic. Paravesical and retrovesical is also there. Parametrium around the cervix, pararectal, paraproctal, retrorectal spaces and paraprostatic spaces. Now, division of the pelvis into floors. Okay. The lesser pelvis is divided into three floors. Which are those? Cavum, pelvis, peritoneal, cavum, pelvis, subperitoneal, cavum, pelvis, subcutaneum. Now, peritoneal is this: cavum, pelvis, peritoneal, cavum, pelvis, subperitoneal and cavum, pelvis, subcutaneous. Now, these are the spaces. Now, what are the superior inferior margin of this? Now, first is cavum, pelvis, peritoneal. Imaginary plane of the inlet of lesser pelvis. Superiorly, there is imaginary plane of inlet of lesser pelvis. Inferiorly, the lowest part of peritoneum is present. And what does it contain? It contains peritoneal organs of the lesser pelvis, upper part of urinary bladder, uterus, supraampullary and ampullary part of the rectum. Next is cavum, pelvis, subperitoneal. In this, superiorly there is peritoneum. See, subperitoneal means superiorly there is peritoneum. Inferiorly, muscle and fascia of the pelvic diaphragm, and it contains extraperitoneal organs of the lesser pelvis. Next is for cavum, pelvis, subcutaneum. Superiorly there is pelvic diaphragm, inferiorly there is skin of perineum, and it contains soft tissue of the perineum and part of some pelvic organs. Next is relation of peritoneum in male and female pelvis. In male, there is rectovascular space between rectum and urinary bladder. Okay, and in females, there is vesicouterine space and rectouterine space. Vesicouterine is between the urinary bladder and uterus, which is all. And next is rectouterine space, which is also called as cul-de-sac of Douglas, which is between rectum and uterus, lowest point of abdominal cavity where pathology tends to occur. Now we move on to the vessels, internal iliac artery and its branches. Now it begins from sacroiliac joint down to the superior part of the down to the lesser pelvis to the superior part of greater sciatic foramen. Then it divides into parietal and visceral branches. Now parietal branches are iliolumbar, lateral sacral artery, superior gluteal artery, inferior gluteal artery and obturator artery. Parietal branches are iliolumbar, lateral sacral, superior gluteal, inferior gluteal and obturator. You just keep remembering parietal. Okay. See, it is giving only to the hip bone and its vertebra. Iliolumbar, sacral, superior gluteal, inferior gluteal and obturator. Fine. Visceral branches, it would give to organs: internal pudendal artery, medial rectal artery, vaginal artery, uterine artery, superior vesicular artery. And also it would give umbilical artery. Okay. Superior, I told already about pudendal artery, superior vesicle, inferior vesicle, superior vesicle and also inferior vesicle would be there. Next is middle rectal artery. Okay. Uterine artery, vaginal artery and also umbilical artery it would give. Now next is venous and nervous plexus, lymphatic outflow of the pelvis. Now venous plexus present around all the organs of lesser pelvis. For example, rectum, there is subserous, subfacial and subcutaneous plexus, and portocaval anastomosis is present. Now nerve plexus are hypogastric and pelvic plexus formed by autonomic nervous ganglia and gives rise to secondary plexus located around uterovaginal plexus. Now lymphatic drainage into the lesser pelvis to external and internal lymph nodes, to common iliac and lumbar lymph nodes, then to lumbar trunk and thoracic lymph duct. Now we would move on to perineum. Now perineum, pelvic floor with associated structure occupying the pelvic outlet. Now borders are anteriorly pubic symphysis would be there, posteriorly of coccyx and laterally there is ischial tuberosity. Now there are two triangles. One is urogenital diaphragm and another is pelvic diaphragm. Okay. Now urogenital diaphragm, it transmits urethra in male and urethra and vagina in female. Now there are two groups of muscles, superficial muscle and deep muscle. Superficially, there is superficial transverse perineal muscle, bulbospongious muscle and ischio-cavernous muscle. And deep, there is deep transverse perineal muscle and sphincter urethra muscle. And in pelvic diaphragm, it transmits anus in both male and female. Muscles are levator ani muscle, coccygeus muscle, external anal sphincter muscle. In topography of male perineum and female perineum. Now we would study various layers. Skin is present, subcutaneous tissue. In male there is Camper's fascia, in females also there is Camper's fascia. Next is superficial membranous fascia. In superficial membranous fascia there is Scarpa's fascia where abdominal superficial membrane. Okay. Colles fascia, it is continuation of Scarpa's fascia and posterior to the scrotum. And Dartus fascia is superficial membrane fascia of the penis. Now, in superficial membranous fascia, in male, there is Scarpa's fascia, Colles fascia, Dartus fascia. Scarpa's fascia is abdominal superficial membrane fascia. Colles fascia is continuation of Scarpa's fascia posterior to the scrotum, and Dartus is superficial membrane fascia of the penis. In female, there is Scarpa's fascia, Colles fascia, and Colles fascia is continuation of Scarpa's fascia posterior to the vagina. Fine. Now these fascia are of superficial membranous fascia. Now next layer is superficial perineal space. In this, there is investing fascia, which is deep, and Gallard's fascia, which is inferior to bulbospongious muscle. Okay. In female also there is investing fascia. Next is Buck's fascia in male, which is superior border of bulbospongiosum. Investing fascia is inferior border of bulbospongiosum, and Buck's fascia is superior border of bulbospongiosum. Next is suspensory ligament of penis, which is continuation with transverse fascia of anterior abdominal wall. Okay. And in female, there is also investing fascia, then suspensory ligament of clitoris, which is continuation with transverse fascia of anterior abdominal wall. Fine. Now you have seen here, in superficial membranous fascia, male have Scarpa's fascia, Colles and Dartus. In female, there is Scarpa and Colles. In superficial perineal spaces, there is investing fascia in male, Buck's fascia in male, and suspensory ligament of penis. And in female, there is investing fascia and suspensory ligament of clitoris. Now, we would move on to the muscles. Muscles attached to the perineal body. There are all four same muscles: superior transverse perineal muscle, bulbospongiosum, ischio-cavernous. Now, in female, there is a greater vestibular gland, which is Bartholin gland, and perineal nerve and membrane is present. Next is deep perineal space. There are muscles which are deep transverse perineal muscle, sphincter muscle, urethra muscle, and dorsal artery and deep dorsal vein of penis, dorsal nerve of penis, bulbourethral gland, which is also called as Cowper's gland. Okay. Male urethra and superior membrane of urogenital diaphragm. In female, there is deep transverse perineal muscle, sphincter urethra muscle, compressor urethra muscle, sphincter uretrovaginalis muscle, dorsal artery and deep dorsal vein of the clitoris, and dorsal nerve of clitoris and female urethra. Next is pudendal canal, which is also called as Allox canal or Canalis pudentalis. Now, what are the borders? Which is formed by sheath of obturator muscle. It contains internal pudental artery, vein and pudental nerve. Topography is out from greater sciatic foramen, lateral to ischial spine and ischiospinous ligament, and enters into lesser sciatic foramen and runs medial to ischopubic ramus. You could see here, see, the pudental nerve, it is running through this canal, which is called as Allox canal, Canalis pudentalis. Next is ischiorectalis rectal fossa. It is a space around the anal canal located between the skin of the anal region and pelvic diaphragm. You can see here ischiorectal fossa. This. It is a space around the anal canal located between the skin of the anal region and pelvic diaphragm. Superiorly, you can see here levator ani muscles are there. Inferiorly, there is perineal skin. Medially, there is anal canal, and laterally there is obturator internus muscle, and posteriorly there is sacrotuberous ligament and gluteus maximus muscle. Content is fatty tissue, and clinical important it is inferiorly called as called as paraproctitis. Fine. Now we move on to the topography of scrotum. Okay. Layers are thin skin, first one, which is thin and dark, covered with sebaceous gland. Superficial fascia, which is also called as Dartus fascia, we have seen in upper section. Continuation with inguinal and perineal connective tissue. Next is external spermatic fascia, continues with the superficial fascia of abdomen. Cremasteric fascia, continuation with intercrural fascia covering the muscle, and cremasteric muscle. Internal spermatic fascia, continuation with transverse fascia. Tunica vaginalis, which is derived from peritoneal vaginal processes. There are two layers, parietal and visceral, and between this cavity, accentuation of fluid is there, and it is called as hydrocele. Now we need to remember one thing, layers of scrotum, it is very important and its origin. Okay, first we would see skin. Okay, next is superficial fascia, skin, superficial fascia, external spermatic fascia, cremasteric fascia, cremasteric muscle, then it is internal spermatic fascia and tunica vaginalis. Now skin, superficial fascia, external spermatic fascia, cremasteric fascia, cremasteric muscle, internal spermatic fascia and tunica vaginalis. You need to remember these layers as it is, layer by layer. Now, superficial fascia, which is also called as dartus fascia. If you don't remember superficial fascia, say it as dartus fascia, because sometimes we would get confused. Okay, again we would keep remember skin, dartus fascia, external spermatic fascia, then cremasteric fascia, cremasteric muscle, internal spermatic fascia, tunica vaginalis. If you don't remember this cremasteric fascia and muscle, keep remember. How to remember this? First is skin, next is dartus fascia, which is superficial fascia, fine. External spermatic fascia, which is a continuation of superficial fascia of the abdomen. Okay, then comes cremasteric fascia. If there is a cremasteric muscle, this muscle should have a fascia, so there is cremasteric fascia first, and then internal spermatic fascia, which is a continuation of transverse fascia, and then tunica vaginalis. Okay, I hope so you remember these layers perfectly, properly. Okay, next is topography of testes. In this morphology it is coated by tunica albuginea. Okay. Next, parenchyma of testes is divided into lobes and separated by septa. Okay. And this parenchyma is composed of semiferous tubules which are convoluted and straight. Later these tubules forms rete testi in mediastinum testi. Then efferent ductules, continuation with epididymis, which is divided into head, body, tail. Its function is production of spermatozoa by seminiferous epithelium of the seminiferous tubules, and testosterone by ladies' interstitial cells. Arterial supplies testicular artery, artery of ductus deferens, cremasteric artery, and venous is pampiniform plexus into testicular vein. Lymphatics is inguinal lymph node, which drains into lumbar lymph node. Nerve supply is testicular nervous plexus. Now we move on to the PA Kuprianov's drainage of the pelvic fatty space. We need to do inferior midline laparotomy. Dressing forceps is used between the lateral wall of urinary bladder and medial margin of the levator ani muscles through the urogenital diaphragm. Okay. Skin and perineum is elevated by the end of dressing forceps. Skin is dissected and a tube is inserted by dressing forceps. Now drainage is done in prevesical space on severe injury. Next is presacral blockade with novocaine. Now little amount of novocaine is taken intracutaneously 1.5 to 2 cm from the anus with a thin needle, then replaced by longer, which is 8 to 10 cm long. Passes through the recto-anal spaces and reaches the rectal spaces. Procedure controlled by index finger introduced into the rectum. 70 to 120 ml, 0.25% of novocaine is introduced. Next is Shkolnikov-Selivanov pelvic blockade. Indication is fracture of pelvic bone. Procedure is long needle 15 cm long near the anterior superior iliac spine along with the ileum to the lateral pelvic space. 80 to 100 ml of 0.25% Novocaine solution is given. Circular excision of prepuce of the penis, which is circumcision. If there is phimosis, then constriction of prepuce that prevents its retraction over the glans penis. If this happens, then this circumcision is done. Procedure is, after local anesthesia, prepuce is drawn anterior and cut off. Edges of internal and external tissue are stitched with silk suture. Now, excision of prepuce. If paraphimosis is happening, which is incarcination of the glans penis by phimotic prepuce. Procedure is, local anesthesia and incarcinated ring is cut through all the layers. Prepuce is moved back to the glans penis. After operation, anti-inflammatory therapy is given. Next is thoracical Gerson's operations for cryptorchidism and monorchidism. Cryptorchidism is anomaly in which both the testes fail to descend into the scrotum and remains either in the abdomen or descends cavity or inguinal canal. Monorchidism is anomaly in which one testis fails to descend. What is the procedure? Line of inguinal incision on line of inguinal canal about a finger, 1 finger's breadth above the inguinal ligament, exposing the superficial inguinal ring. Now, aponeurosis of external oblique muscle is slit and testes is exposed. Covering of spermatic cord are freely divided and relation of the testes to vaginal process are determined and vaginal processes and divide the vaginal process. The testes can be brought down to bottom of the scrotum. If not possible, then vas deferens with the accompanying artery must be separated from other constituents of the cord and held aside. Spermatic vessels are dissected upward in extraperitoneal tissue for several inches. With a finger, a bed for the testes is made in the scrotum. A chromic gut suture through inferior pole of the testes, including tunica albuginea, and 2 ends of the sutures brought out separately through the lowest part, which is 1.1 to 5 cm apart. Then tied over a small piece of rubber tube to avoid strangulation of the skin. In case of incomplete descent of the testes, complicated by hernia, the vaginal process, which has been divided in the course of operation, must be obliterated. Highest accessible point in the canal. Next is Winkelmann's operation of hydrocele. It is done if there is accumulation of fluid in cavum vaginally. Procedure is, patient lies on back, local anesthesia is given, incision of 8 cm above the inguinal fold till the base of the scrotum is done. Skin, subcutaneous tissue, cremasteric muscle, internal spermatic fascia is incised. Fluid filled mass is taken out through the wound. Pressing its inferior fold through the scrotum, content of tunica vaginalis is removed by puncture with trocar. Serous layer is cut longitudinally and turned around the testes and spermatic cord and edges with catgut sutures. Hemostatic therapy is given and wound is stitched layer by layer. Next is Bergman's operation for hydrocele. Hydrocele with thickening of testicular layer. Procedure is puncture and incision of tunica vaginalis. Remaining layers are stitched with continuous catgut suture and wound is stitched by layer by layer. Topography of urinary bladder. Now, morphology is base, apex, body, trigone, neck and uvula is present. Base, which is also fundus of bladder. Apex, here. Body of the urinary bladder. Neck and see, this is the neck of bladder and uvula. Layers are serous layer. Okay. When urinary bladder is full, then it is mesoperitoneal. When it is empty, then it is extraperitoneal. Muscular layer of external, it is long fibers. Middle, it is transverse or circular fibers, and internal there is long and transverse. These 3 layers of muscle fibers form pubovesical muscle. Then there is submucous and mucosal layer. Function is reservoir of urine. Holotopy is projection on suprapubic region. Skeletopy is at the level of pubic symphysis. Syntopy is posteriorly, there is seminal vesicles, terminal part of the different duct and rectum in males, uterus and vagina in female. Artery, superior and inferior vesical artery, middle rectal artery, venous is vesicular venous plexus and internal iliac vein. Lymphatic is internal iliac lymph node and nerve is nerve plexus of urinary bladder. Next is topography of ureter. Two parts is distinguished, abdominal and pelvic. Layers are adventitious layer, muscular layer, outer and inner, outer longitudinal fibers, inner circular fibers, and mucosa layer is present. Functions is delivering of the urine from the kidney to the urinary bladder. Holotopy is projection along the margin of the rectus abdominis muscle. Skeletopy is initial part, first and second lumbar vertebrae. Artery, renal artery, testicular artery, ovarian artery, uteric branch of internal iliac artery, middle rectal artery, inferior vesical artery. Venous is testicular vein or ovarian vein, then and internal iliac vein. Lymphatic is sacral and internal iliac lymph node. Nerve supplies uteric, renal, hypogastric and testicular ovarian plexus. Now next is topography of prostate. Now morphology of the prostate's parts are base, apex, median lobe, which is also called as isthmus. Function is secretion of proteolytic enzyme, acid phosphate, fibrinolysin and citric acid, acting as a sphincter for urethra to prevent the flow of urine during ejaculation. Holotopy is projection on the suprapubic region. Skeletopy is behind the pubic symphysis. Syntopy is anteriorly there is pubic symphysis, posteriorly there is rectum, superiorly there is urinary bladder, inferiorly there is bulbourethral gland and lateral there is seminal vesicles. Artery is inferior vesicular artery and middle rectal artery. Venous drainage is vesical plexus and prostatic plexus into the inferior vesical vein. Lymphatic drainage is sacral, iliac and internal iliac lymph nodes, and nerve supplies hypogastric plexus. Topography of seminal vesicles. Morphology is duct of seminal vesicles plus duct of deferens is ejaculate. It thus forms ejaculatory duct. Projection on suprapubic region at the level of pubic symphysis. Skeletopy it is. Syntopy is anterior, posterior, medial. Anteriorly, there is fundus of urinary bladder, posteriorly rectum, medially ampulla of the different duct. Artery is inferior vesicular artery, artery of different duct, middle rectal artery. Vein is vein of the different duct into internal iliac vein. Lymphatic drainage into the internal iliac lymph node and nerve supplies hypogastric plexus. Topography of different duct. Morphology is component of spermatic cord. Distal part is called ampulla. It unites with seminal vesicles to form ejaculatory duct. Function is conveying spermatozoa from epididymis to ejaculatory duct. Holotopy is projection on suprapubic and inguinal region. Syntopy is in pelvis, crosses external iliac vessels, then between urinary bladder and urethra. Then joins up with duct of seminal vesicle. Artery is artery of different duct. Veins is veins of different duct into internal iliac vein. Lymphatic drainage is into internal iliac lymph node and nerve is hypogastric plexus. Topography of uterus. Morphology is fundus, body, isthmus and neck which has internal os and external os. Okay. Layers are parametrium, fatty tissue of the layer, myometrium, muscular layer, endometrium, mucous layer. Function is place of implantation and growth of fetus, place of menstruation. Holotopy is projection on suprapubic region. Skeletopy is at the level of pubic symphysis. Syntopy is anteriorly urinary bladder, posteriorly rectum. Artery is uterine artery, ovarian artery, partly. Venous drainage, uterine plexus into ovarian vein and ovarian vein and internal iliac vein. Lymphatic is sacral, iliac and internal iliac lymph node. Nerve is nerve plexus of the uterus, uterovaginal and hypogastric plexus. Next is uterine tube. Morphology is fimbriae, infundibulum, ampulla, isthmus, uterine part and uterine ostium. Layers are serous, subserous, muscularis, mucous layer. Muscularis, outer and inner, outer longitudinal, inner circular. Function is passage of spermatozoa to reach the primary oocyte. Place of fertilization in the ampulla part of the uterine tube, conveying fertilized egg to uterus. Skeletotopy is at the level of pubic symphysis. Synotopy is situated into the broad ligament of uterus near the ovary. Arterial supplies tubal branch, uterine and ovarian artery. Vein is uterine plexus into ovarian vein. Lymphatic is sacral and iliac lymph node, and nerve is uterine nerve plexus. Topography of ovary. There are two ends, tubal and an uterine end, two margins, anterior mesovarium border, posterior mesovarium border, two histological parts. Ovarian cortex consists stroma with ovarian follicles, and ovarian medulla consists of connective tissue. Function is production of oocytes, estrogen, progesterone, inhibin, foliostatin and activin. Holotopy on suprapubic region, skeletotopy at the level of pubic symphysis. Synotopy is situated in the broad ligament of the uterus, which is mesovarium, near the fimbriae of the uterine tube. Arteries, ovarian artery, ovarian branch of uterine artery, and venous is right side right ovarian vein into inferior vena cava, and left is left ovarian vein into left renal vein. Lymph is sacral and iliac lymph nodes. Nerve is uterine and hypogastric plexus. Now, ligaments of internal genitalia. There is broad ligament of uterus, which is peritoneum which connects uterus to the lateral wall of the pelvis, which is mesosalping, mesentery of uterine tube, mesovarium, mesentery of ovary, mesometrium, mesentery of uterus. Round ligament of uterus, ligament rotundum uteri, ligamentum teres uteri. Connects the superior angle of uterus to the deep inguinal ring. Terminates at connective tissue of mons pubis and labia majora. Next is uterosacral ligament, posterior part of uterus to anterior part of sacrum. Cardinal ligament, which is transverse ligament, McEnroth's ligament, ligament cardinal, which connects the inferior part of uterus to the lateral wall of pelvis. Ligament of ovary connects uterine end of the ovary to the fundus of uterus. Suspensory ligament of ovary connects ovary to the pelvic brim. There are 5 parts of the rectum: supraampullary, superampullary, midampullary, inferior ampullary, perineal. There are 2 flexures: sacral flexure, perineal flexure. Sacral flexure is upper flexure convex posterior to the sacrum. Lower perineal flexure is lower flexure convex anterior to the coccyx. Serous, there are layers. Serous layer, which is a peritoneum, superiorly intraperitoneum, middle mesoperitoneum, lower extraperitoneum. Muscular layer, outer longitudinal, inner circular, thick pectineal line to form internal anal sphincter muscle. Submucous layer contains internal rectal venous plexus, dilation and prolapse of this plexus, internal hemorrhoid pits. Thrombosis is external rectal venous plexus in the perineal space. External hemorrhoids are like piles. Mucous layer contains anal column and anal sinuses, anal sinus and crypts, which is a common site for pathogenic microorganism and spreads to the paraprocticum, causes paraproctitis. Function is retention and evacuation of the feces. Holotopy is projection on suprapubic region. Skeletotopy is superior part into the third sacral vertebrae. Synotopy is anteriorly seminal vesicle, different duct and urinary bladder, uterus and vagina. Posteriorly sacrum and coccyx. Superiorly sigmoid colon. Artery is superior, medial, inferior rectal artery. Venous drainage is superior rectal vein into inferior mesenteric vein into portal vein. Middle and inferior rectal vein into inferior vena cava. Portocaval anastomosis forms in rectum. Lymphatic drainage is sacral, inguinal and iliac lymph nodes. Nerve supply is inferior hypogastric and aortic plexus and pudendal nerve. Operative access to the pelvic organ is inferior median laparotomy, Pfannistelian's horizontal inferior laparotomy, oblique dissection in the inguinal region. Next is capillary puncture of the urinary bladder. Indication is retention of the urine and failure to evacuate it with catheterization. Procedure is patient lies on the back with pelvis slightly raised. Then puncture is made in the middle 2 cm above the pubic symphysis, needle with a small diameter to avoid the leakage of the urine into the pre-vesical fatty spaces. Needle is inserted with 6 to 8 cm in depth perpendicular to the point of body. If urine flow is not happening, a suction pump is used. Next is opening of urinary bladder. Suprapubic cystotomy is done, which is section of sexio alta. Indication is urolithiasis, foreign body of the urinary bladder, surgical approach to the prostate. Patient lies on the back, local infiltrative anesthesia is given. Prior to the operation, urinary bladder is processed through rubber tube, Kocher's forceps to extend the end of the tube. Incision is made 3 to 4 cm from the umbilicus to the pubic symphysis. Skin, subcutaneous tissue, aponeurosis of white line is dissected. Pyramidalis and rectus abdominis muscle is moved apart. Laminar surgical retractor. To gain the access to prevesical fatty spaces, transverse fascia is cut horizontally above the pubic symphysis. To expose the urinary bladder, move the transverse fascia, prevesical fatty tissue and prevesical fascia is moved up. Muscular and mucous layer is dissected. At this moment, Kocher's forceps is removed from the tube and fluid is freed. Open the bladder, surgical intervention is done. For example, extraction of stone and electrocoagulation. Continuous catgut suture to muscular layer of wall of bladder. Drainage tube is into prevesical space. Abdominal wall is sutured layer by layer. Edges of rectus abdominis muscle by interrupted catgut suture. Edges of aponeurosis by silk suture. Skin by interrupted silk suture. Tension suture above the drainage, and drainage tube is removed 4 to 5 days time. Drainage of prevesical space. Drainage of this space is dissecting the anterior abdominal wall. But in neglected cases with sign of phlegmon, drainage is done through obturator foramen. This operation by Buliansky-Mackiotter's technique. Swelling of phlegmon of prevesical space. Patient lies on back with abduction of lower extremities. Local anesthesia is given. Transverse incision on the internal surface of thigh. Skin, subcutaneous tissue and proper fascia is dissected. Abductor longus and brevis muscle is moved apart in the blunt way to penetrate the adductor minimus muscle. Prevesical fatty tissue penetrates through obturator external muscle, obturator membrane and obturator internus muscle and anterior margin of obturator foramen. Through this opening, drainage tube is inserted for outflow of the pus and administration of antibiotics is done. Operation for extrauterine pregnancy. Indication is extrauterine pregnancy. Procedure: patient lies on the back, general anesthesia is given, lower middle laparotomy or Pfannenstiel incision is done. Through the fundus, catgut ligature is done. To react uterus, Meiosis forceps is used. Uterus, the indicated tube and ovary are taken out through the wound. Clamp is applied to the uterine part of the tube, another one to the suspensory ligament of ovary parallel to the tube. According to the size of excision of the tube, 2 to 3 hemostatic clamps are applied to the mesosalpinx. End of the tube near the uterine angle is excised in the V shape, not more than 5 mm in depth. Whole tube is then removed. To injured uterine angle, 2 to 3 catgut suture is applied. Peritonization is done on injured surface with stitching of the continued catgut suture. Uterine angle is covered by peritoneum. Serous suture is applied to the anterior and posterior surface of mesosalpinx. Round ligament used for peritonization of the uterine angle. After removal of the blood clots and observation of appendages of uterus, abdominal wall is stitched. Puncture of rectouterine pouch. Aspiration of fluid from this region for analysis is done at the posterior fornix of the vagina. Next is adenomectomy. 4 methods to approach the prostate is transvesical, perineal, transurethral, retropubic. Now, excision of the prostate capsule by perineal and transurethral approach. Tumor of prostate by suprapubic and perineal. Now, if there is purulative disease of prostate or prostatic adenoma, then patient is in Trendelenburg position. Local anesthesia and general anesthesia is given. Rubber tube is introduced. Urinary bladder and suprapubic cystotomy is done. Incision is done on the mucous layer of bladder 0.5 to 1 cm from the internal urethral orifice. Through this, index finger is inserted into the mucous layer and got into the space between adenoma and prostatic capsule. When surgeon reaches the spaces, he will make round exfoliation of the adenoma. For removal, transverse incision of the urethra at the level of anterior margin of prostate is made. Cystitis, 2 stages operation is there. Urinary fistula is applied for urine outflow. When inflammatory process ceases, adenotomy will be carried out. Next is Zerinin Kummel Gerson's fixation of the rectum to the sacrum. Procedure is patient is in Trendelenburg position. After lower middle laparotomy, small intestine is moved up, large intestine is moved to the left. Peritoneum is cut on the right from sacral promontory till the third sacral vertebrae. 4 form silk suture to the anterior longitudinal ligament of vertebrae. Rectum is then pulled up. Posterior lateral surface of the rectal wall stitched to the left end of the ligature. Right border of the free margin of peritoneum is stitched to the anterior lateral surface of the fixed rectum. Through anus, rubber tube is inserted into the rectum. Upper end of the tube higher than the sacral promontory. Abdominal cavity stitched layer by layer. Rubber tube is removed on second or third day. Ligature of hemorrhoids, which is piles. Hemorrhoids from the hemorrhoidal leading to anemia. Frequent prolapse of enlarged hemorrhoid. Complication of hemorrhoids with inflammation and strangulation. Contraindication is acute inflammation and strangulation of hemorrhoids. Local anesthesia of the skin subcutaneous spaces around the anus is administered. Tortuous layer of rectum. Index finger is inserted into the anus. Novocaine solution is given into the sphincter of the rectum and ischio-anal fossa nearly 7 cm in depth. External anal sphincter is stitched with 2 hands. End of the clamp reaches the hemorrhoid. Mucous layer is cut off. Base of the hemorrhoid is stitched with a thick silk suture and tightly tied. Clamps are removed with ligating suture cut off. 6 to 7 days hemorrhoids will tear off. Next is Whitehead's plastic reconstructive operations for hemorrhoid. It is done for chronic hemorrhoid with relapse. Procedure is hemorrhoids are excised through together with the cylinders of mobilized mucous membrane of the anus. Operation for paraproctitis. It is inflammation of paraproctium, which is tissue around the rectum and anus. Basic principle is drainage of abscess and elimination of its internal opening. Drainage of abscess by semilunar incision. Pus is drained out. Grooved probe is delivered from the wound through the opening of the rectum. Sinus tract is dissected through the probe. Perineal skin is excised in triangular form with its apex directed to the anus by Gabriel. Several types are there: subcutaneous, submucous, ischiorectal, pelviorectal and retrorectal. Subcutaneous excision is radically above the focus of inflammation. Submucous, dissection of abscess from the opening of the rectum. Longitudinal incision is done. Dress the wound by H2O2 and 2 to 4% of potassium permanganate solution. Tampon is inserted into the rectum with Wisniewski's ointment. Ischiorectal excision, height of infiltration is done 4 cm away from the anus. If infiltrated diffuses, exusion is extensive. Purulent area by H2O2 2 to 4% of potassium permanganate solution. Tampon with ointment is inserted. Pelviorectal, anus is wide with rectal speculum. Abscess puncture with the thick needle through which pus is received from the rectal wall. In the cavity of open abscess, drainage tube is introduced. For women, abscess is dissected by posterior vaginal fornix. Next is operations for rectal cancer. There are 2 methods: palliative, radical. Palliative is performed with the formation of fecal fistula and anus parectate urealis. Radical is remove the part of the rectum together with regional lymph nodes, fascia and cellular space. Now radical, there are 3 main types: resection, extirpation, amputation, and ways of approach is perineosacral, abdominal, combined. Subtypes of radical operations is one stage of the abdominal perineal extirpation of the rectum, which is operation by Keynes-Mellis. Intra-abdominal resection of the rectosigmoid section, anterior resection of the rectum is done. Abdomino-anal resection of the rectum with the preservation of the sphincter, operation with bringing down. Intra-abdominal resection of rectum and sigmoid colon, Hartmann's operation, which is perineal amputation of the rectum. Resection, extirpation, amputation. Resection is intraperitoneal, extraperitoneal. Aim is excision part of the rectum with some restored or removing whole rectum with preservation of the sphincter. Removal of the part of the rectum without restoration of continuation but with preservation of distal excision of rectum. Extirpation is rectum is removed without restoration of continuously. There is two stages of removal of the lower part of the small intestine with rectum and anal sphincter. Amputation, distal part of the rectum is removed by bringing down the central stump down to the level of perineosacral wound. One stage peritoneoperineal extirpation of the rectum. Rectum is removed with anus plus anal sphincter plus fatty tissue with artificial anus is formed from sigmoid colon. Peritoneal stages, inferior midline laparotomy is done. Sigmoid and descending colon is pushed laterally. Peritoneum is cut 4 cm above the sacral promontory at the 4th cervical vertebrae and continues along right border of the rectum. At the level of the rectouterine pouch or rectovesicular pouch, incision continues in the transverse direction, then upward to the level of the beginning of the incision like a U shape. Mobilization of the sigmoid colon, ligature of the vesicle in the mesocolon sigmoidum. Rectum is separated from the sacrum, blunt way with proper fascia, fatty tissue, lymph node up to the apex of coccyx. Rectum is separated from the lateral wall of the pelvis partly blunt way and partly by scalpels. Surgeon must be very careful to prevent the penetration of uterus and vagina in the females and urinary bladder in male during the separation of the anterior part of the rectum. Sigmoid colon is cut both ends, ligated and applied by iodine, which prevents infection, and distal end is put down to the floor of the pelvis and peritoneum will be stitched over this. Proximal end is drawn out to the anterior abdominal wall forming colostomy. Peritoneum is stitched to the mesocolon sigmoidium. Wound of the anterior abdominal wall is closed. Perineal stage, anus is stitched by purse string sutures, 2 oval incision around the anus, margin of removed skin by silk suture, fibers of levator animuscles are cut. Rectum is removed together with lymph vessels and fatty tissue of ischiorectal fossa, ligature of the vessels, closure of the perineal incision by silk suture. One stage peritoneoanal resection of the rectum with the preservation of the anal sphincter. Rectum is removed with the part of sigmoid colon, but sphincter and external muscle is preserved. Rectum is replaced by sigmoid colon, sphincter is preserved and its function. Peritoneal stage, mobilization of the sigmoid colon. Length of the sigmoid colon must be enough to pull down to the plane of rectum. Sigmoid colon is pulled down to the lesser pelvis as much as possible without any tension. Pelvic peritoneum is restored. Anal stage, stretch the anus to the mucous layer of the rectum and is cut at the boundary of the skin around the anus. Separated from the muscle 4 cm from the anus. Margin of the mucous is close to the lumen of the rectum. Transverse incision 4 to 5 cm anterior to the coccyx. Anal coccygeal ligament is cut. Axis lesser pelvis. Muscular layer is cut above the sphincter ana muscle by Cooper's scissor. Rectum is separated from vagina in female and prostate in male by the blunt sharp way. Rectum is pulled down through the anus. Sigmoid colon is stitched to the margin of the anal wound. Part of the rectum with tumor is removed. Tampon of the wound is in the coccygeal region is applied and anterior abdominal wall is closed. So till now we have studied all the topics of topography and operative surgery, topographical anatomy and operative surgery. So this was our last chapter, pelvis and perineum. I would post many videos, shorts according to the need. So till here I complete all the chapters of the topographical and operative surgery. So keep learning, keep update on the YouTube channel. So I would post all the videos, all more videos, informative videos which would help you in the studies. Thank you.